Hello.
Hello. Yes, Pramod. I think everybody is mute.
Pritam?
Please go on. Yes, Pramod.
Yeah. Thanks, Pritam. This is a great initiative, and today is one of the most important days when we have our mentors, our gurus here. It's a great feeling, actually. As you said, this is just a spark which has caught fire. You see, it's amazing how in 3 days, this has taken off. Um, and what we are currently doing is that we have a Zoom platform and a YouTube platform. And if anybody wants to pose a question to the people who are discussing, the only people talking would be the host of the meeting, Dr. Kishore, and the co-hosts on Zoom, that is Dr. Krishnamurthy and Dr. Sanjeev. Nobody else, unless they are asked a specific question, nobody will be speaking in this session at all. So, but in case the people on Zoom and people on YouTube, if you want to pose a question, you can use your chat window either on the YouTube or on the Zoom and direct your questions to the Zoom co-host or the co-host on the YouTube. Back to you, Preetham. And these questions will be taken up for discussion according to their merit by the team on the Zoom. Yeah,
Thank you, Pramod.
carry on, Preetham.
Yes.
Yeah.
Other than Pramod, there are two more people who are working behind the scene for us. One is Amit. Amit, are you there? Praveen, let Amit in. And Dr. Kannan, who's the chairman of the webinar, who've been tirelessly working day in, day out, introducing to the co-host, bringing up the co-host for us. Amit and Kannan have been doing extreme work behind they are the workforce behind the back. All this was possible only if we had a technical head. And I have no words to thank A1 Logistic and Praveen for the wonderful job they're doing, helping us. Every day we are coming up with new demands. We are telling, mute this guy, do this, do that for us, and flyers. Basically, what we are doing right now is, as this web series gets over, we prepare for the next web series. So the tomorrow's web series, we do a demo for them, then we run the actual web series. A lot of hard work these three guys are doing, and plus Praveen, they're doing a wonderful job. For coming up for the today's event, when as the web series started, we also got to realize that this is becoming IPL of India, academic IPL. So we thought that we should have a music. So we have today our president and president-elect, Dr. Veerabhavu and Dr. Manjunath Rai. Praveen, can you let Dr. Veerabhavu and Dr. Manjunath Rai video on, please? I would request Dr. Veerabhavu to release the music for the event. This is a AOMSI web series music. Praveen, let Dr. Veerabhavu in, please. Praveen, is Dr. Veerabhavu there? And I request our president, Dr. Veerabhavu, to release the music for the web series.
Hi.
Yeah, please release the video music for the web series.
Yeah. Digital release.
Thank you, Praveen. Thank you, President, sir. This video was composed by our member, Dr. Pradeep Christopher. Thank you, Pradeep, for the wonderful job you have done. He was supported by one of our dentist friend, Dr. Santosh, who helped us to get the tabla in to get the Indian touch. Now, Praveen, please release the co-host for the program today. We have two co-hosts for the YouTube. We have Dr. Kumar and Dr. Jimson, who's going to collect the questions from YouTube and pass on to our main co-host of the day, Dr. Sanjeev Nair and Dr. Krishnamurthy. Praveen, can you get the co-host, please?
Yeah, they are in.
They're in. Okay. Okay. I like to pass on this to our main co-host now, Dr. Sanjeev Nair and Dr. Krishnamurthy, who will introduce our speaker of the day. So the wonderful thing for all the AOMSI members today is we have three past presidents of AOMSI who are going to address us today. Praveen, please get us Dr. Sanjeev Nair and Dr. Krishnamurthy, please.
I'm going to mute everyone and I'll let unmute.
Only Dr. Sanjeev Nair and Dr. Krishnamurthy.
Yeah.
Hello, can you hear me?
Yes, sir, we can hear you. Sanjeev, sir, please.
Okay.
Praveen, Sanjeev, sir, please.
Done.
Okay, so over to Dr. Sanjeev Nair and Dr. Krishnamurthy. Sir, please take over, introduce the speaker, and you can start the webinar. Thank you, sir. Thank you for accepting our invitation.
Thank you, Preetham. Do you want to start, Kita, or should I start?
You start.
Okay. Thank you very much, Preetham, for this opportunity. And I can see that you're doing a great job, your team and everybody behind it. Kudos to the excellent presentations that have happened till now. And I suppose this is going to be a break between all the serious presentations. So I would say let us enjoy ourselves. And for that, we have none other than our very, very important past president and the person who was significant enough to kind of change the way the specialty was practiced in the country. We have Dr. Kishore Nayak. I'm sure none of you, either in India or around the world, require an introduction of him. But there are a few things that I need to say. He is our past president of the AOMSI. He's also the past president of the International Association of Maxillofacial Surgeons. He's been behind many of the policies that have been taken behind in the International Association as well as in the National Association. He has always been a mentor, a guide. He's been my partner in practice and crime. And I present to you Kishore. I'm sure Kita would also have a few words to say about him. So Kita, you can join in.
Thank you, Sanjeev, and thank you, everybody. Welcome you all to this rather nice webinar series in the times of Corona. I just heard Preetham call this as the IPL. So if this is the IPL of AOMSI, the cheerleaders can't be far away. So we are going to see the pajama maxillofacial surgery, I believe, in the next few weeks while we sit at home and twiddle our thumbs. When we decided to do this chat with Kishore Nayak, we were wondering how to take this thing forward. I'm not a great fan of Gabriel Garcia Marquez, but one of the other chaps who followed him on and ignited the field of what they call magic realism in fiction is Salman Rushdie, and I'm a fan of his. So there is a title, one of the famous books that the Nobel laureate Gabriel Garcia Marquez wrote, and that was called Love in the Time of Cholera. So from cholera, we have now reached Corona, and all we can do, as I said, is to sit and talk about it. And so I thought we would call this Conversations in the Times of Corona. We are getting a lot of information about Corona. In fact, this is something that is developing as we go along. So there are so much of misinformation as compared to information, starting from a simple tweet misusing the photograph of Ratan Tata to seriously coming out with all kinds of outrageous claims. That's been the order of the day in this post-truth era. And therefore, we are not going to waste our time or Kishore's time in asking him to give us more information as it gels on, we go along. But what we are going to do here is to get onto a philosophical plane and look at some philosophical as well as some very practical questions that might be bothering the minds of our specialty today, particularly, and as human beings in general. So who else than Kishore Nayak to do this kind of an introspection for us? Someone who can very, with his own sense of humor, someone who can tell us the bitter truth, call the spade a spade as we go through these tough times. Kishore, can we start now?
Thank you, Kita. Am I audible now? Am I audible?
Yes,
Yes,
you
sir,
are.
you're audible.
Thank
You
you.
are.
You know, when Preetham asked me about 5 or 6 days ago to do this, I was very hesitant for the same reason that Kita has already said. I mean, you know, the amount of information overload we have had on Corona and COVID has been enormous. And I thought maybe there's really nothing I can contribute to on it. And then I had second thoughts and said, well, why not we inculcate a way of thinking, you know, that let's try and approach this as a crisis and how we could fight out of a crisis, a way out of a crisis. Just, you know, the thing I said, I have not spoken at an AOMSI forum now for about 8 years, really by choice, not for anything else. But I'm glad to be back because AOMSI has been a major part of my life. A majority of my life has been devoted to the AOMSI. And I'm glad to be here sitting with friends and making this presentation. So as we said, we're going to have conversations in the time of Corona. And I think as we go along, rather than a very technical note, let's just put a disclaimer here. We are not really going to try and tell you how to deal with Corona. But I think we're going to try and say, how do we work around the effects of Corona? How has it affected our specialty? And having it stare us in the face, how we move on from here. And that's really going to be the theme of this interaction. This is not going to be a monologue. Sanjeev and Kita, and I'm told Deepak, who's sitting in Cincinnati, will also contribute as and when we need him. So certainly not a monologue, and let's carry on and see what we can derive in the next half an hour or so in our thoughts on how to deal with this time of Corona. You know, this has been the guiding philosophy in my life that, you know, I'm not going to worry about factors which I have no control on, but I'll worry about problems which I can influence. And I think as far as Corona is concerned, that's the only thing we can do, because there are some factors that are in our control, and we need to try and deal with that as individuals, as an association, and as practitioners of this specialty. And we don't go really beyond that. Now, yesterday, somebody asked me, you know, why is Corona happened? Is it because of globalization? And I think that's not strictly true, because even before the era of globalization, if you go back 6 or 7 centuries, the Black Death, the bubonic plague, wiped out close to 200 million people in the entire world. So certainly we just can't blame globalization and people traveling easily between continents for that. Humanity and mankind has faced these issues before, and we're going to continue to face them. We are going to face them again and again. Not far from here, 100 years ago, you know, the Spanish flu came to India and apparently decimated about 5% of our population. And yet we don't really relate to this because perhaps none of us were alive at that time. Apparently 17 million people died in India. I'm sure Corona will not reach anywhere near that mark, but nevertheless, it is something that has happened in our country. And in that time when there was lack of information, lack of awareness, I really don't know how people dealt with it. And here we are, an overload of information and facing the problems that we are now. Now, interestingly, even if you look at, this is a very interesting book for some of those who may or may not have read it, Guns, Germs, and Steel, when the conquistadors, the Spanish and the Portuguese landed in South America, it was not their guns and steel, it was not the guns and swords which decimated the population, but they conquered America because 95% of the population of South America got decimated by smallpox. Now, it's arguable whether that decimation happened intentionally or by accident, because it is said that, they gave them infected clothes and everything else that went with it, and then they really didn't have to do anything, and in a jiffy, South America was altered. So will COVID do that to us? I think we have to be optimistic, because when you look at India, if you just go back 4 or 5 decades ago, in about 10 years, the world conquered smallpox. And India's journey in conquering smallpox and polio was an incredible one. Last year, we did not have a single person infected by smallpox or by polio. So I think even historically, if you look at what India is capable of, in those times, with perhaps lack of information and lack of a regulated healthcare system, we could do it. There is no reason why we can't deal with Corona now. And again, I must insist, as we go along, I think the three of us are just going to try and inculcate a thought process. We're not going to come with solutions. We'll perhaps, if you can go away from here today thinking, look, I can deal with this problem, and in a few months we will have a solution, I think that's a job well done. Peter?
So, like I said, I started off with a list of questions that I posed to Kishore as to the direction where this conversation should take. And what better question than to ask what kind of an impact this novel virus, let's discuss about the novel virus later on, but this novel virus has had on our specialty in particular. Kishore?
I like to always pull up anecdotes and stories, Kita.
Yeah.
And today is Easter Sunday. So why not talk about something to do with Easter and Christianity, And this is the story that when when Nero was persecuting the Christians in Rome, St. Peter, who you see on your right, was running away from Rome. And he encountered resurrected Jesus, who was walking back to Rome. And St. Peter asked him, Quo vadis? Where are you headed? Where are we headed? And Jesus said, I am going back to Rome to be crucified again. And that changed St. Peter's mind, and he headed back into Rome. And as a result, he did not meet the same fate as Jesus, but he was crucified head side down. And that, I think, is really something that COVID has done to us. It's turned the specialty and the way we are thinking on its head. If you asked us 2 months back whether this was possible, some Corona-like scenario was possible, so answer would have been certainly no. We couldn't even imagine that something like this. But yet here we are all sitting at home, entirely turned around, wondering what to do next. So when we ask ourselves, will COVID affect us as a specialty? I think almost certainly it will. It has already affected. And as we can already see, hospitals are telling us that we are going to focus only on priority areas, and elective cases are not going to be taken up. Interestingly, I was speaking to somebody yesterday. He said, yeah, we can do malignancies and we can do trauma. And in England, of all the places, I was told that if a malignancy walks in, you can do the resection, but you can't do the reconstruction. Now, I think all said and done, when you take approaches like that, you are doing a great disservice to the patient and to ourselves, because you're subjecting the patient to two major procedures, which could have perhaps been done in one stroke. But nevertheless, these are things that we can talk about as to what we can do and what we can't do. But in the overall scheme of things, if you look at a majority of the things that we do, cleft lips and palates and orthognathic surgery and aesthetic surgery, I think they are currently all out of the window. We have no occasion, no place to even do them at this point in time. So are we affected as a specialty? Most certainly we are, and we are affected greatly. And as a result, there are huge financial implications for individuals, especially younger surgeons who might have loans to pay, bills to pay, and lots of other financial implications for them. So certainly, yes, very, very short answer to your question. Yes, a big yes. We have been affected and we need to find a way out.
You spoke about globalization, isn't it?
Yeah.
And in terms of globalization, do you think anything, the speed of travel has got to do with the way we have, actually had the infection spread globally at the same time or close to days apart?
It probably has, Sanjeev. I don't know the answer to that. But, infections, viral
So,
infections.
Kishore,
Yeah.
before we go on to the next question, can we pause and
Yes. Is there a reason to pause? Gita? Was Gita saying something?
I think, sir, you
Yes,
can continue,
well-
sir. He got muted. Yeah.
Okay, so why did he mute? Did he mute himself, Praveen?
Maybe some network issue, sir, at his end.
Okay, so sir, between you and Sanjeev, sir, you can continue, please, sir.
Yeah, Kishore, you were mentioning
yes,
about
please.
globalization. Yeah, and the speed of travel, which has. Kishore.
Yes, I mean, I heard you there, Sanjeev, but I don't have the answer to that. If you go by history, I mean, without high-speed travel, without intercontinental travel being as routine as it is now, infections have spread across countries and across continents. So yes, definitely it has. For example, if you look at the incidences in New York, certainly it has been carried from China to New York, but I have no real answer for that. I'm not an epidemiologist. I really can't put a finger on that and say, has it really speeded it up? By all evidence, yes. But would it have happened without globalization? I would still think, yes, it would have happened without globalization.
The other interesting thing, I suppose, is how, I mean, earlier, if you look at the world wars, each world war has thrown, has changed the world upside down, like you showed. The crucifixion of upside down. So each world war has actually thrown out changes in the world order, changes in important policy decisions have been made. After the two world wars, there was the Cold War that came in. So every time there has been some paradigm shift in the geopolitical situation of the world. So do you think that there will be such a geopolitical change in the way the world will evolve after this pandemic? Hopefully that
I think as we go on in the lecture, some of those questions may be answered.
Right.
So I would suggest that we carry on. If there's no other point, let's carry on, and then we can, probably come back to some of these questions at the end.
So you can carry on then, Kishore,
Okay.
because I think there's some glitch with.
Okay. So this was the question I think either you or Kita had posted to me.
I was supposed to ask you about. See, I mean, one of the things that I'm sure is in the back of everybody's mind is on, Kyo. I mean, what are we going to do about not only the practice, but what really should matter to everybody is also the finance that is impacted, the economy that is going to be impacted, not only the economy in general, but your personal economy. So do you have any answers to that, Kishore?
Let's try to answer it. Let's see whether we can make it a part of the discussion. I may not have a specific answer that can solve a specific problem for an individual, but maybe we should generalize as we go along. And I think that is really something that is there within the scope of this lecture, along with, like I said, the way we think and approach this problem. Do you have anything to add, Kita, at this time?
Yeah, I just lost the connection. I just want to ask you something. This economic thing, it's like drying up of income completely for all of us, whether we are struggling, whether we had a lot of income coming in. So how do we approach these things? One specific thing I want you to address while you go along with all your philosophies that the Reserve Bank of India has said that there is a moratorium on paying all your EMIs.
For 3
How
months.
do you see this? Is this a good opportunity or it's better to avoid?
What do you mean to avoid paying the EMIs for 3 months? Is that what you're asking me? Hello?
Yeah, I think that's what he meant. Yeah.
I think
Yeah, that's
certainly.
what-
I mean, why
that's
not?
what it is.
I would say.
Yeah, that's right. So do you
Again,
think that it's a good idea to?
Definitely. I would say in one word, definitely, yes, you should. You should avail that.
No, one of the issues is the interest mounts, right? Your on the interest doesn't stop getting calculated. The meter runs. So so will it be a problem later on if you try to postpone this issue?
Well,
of course, if it's inevitable, then
yeah, I think you'll have to look at it based on your personal circumstances. And I think,
right.
If you're in a position to pay it off, it is wise. But I think if you can't, it's a great opportunity to defer it. And
Right.
hope that the government does even more for you
Right.
in terms of deferment of interest as well. I do not know whether that will happen, but it might happen.
Okay.
But
Carry on, Kishore. I'll
it's-
ask my other questions later on.
Yeah.
Yeah.
I think, one of the things that has influenced me in the last 1 year is the writings of Yuval Noah Harari. I think many of you have read him. And I think he gives a great progression of how we as humans have actually probably destroyed nature to a large extent and denuded the earth a lot, what we would be doing as we go along in Homo Deus, and offers solutions to that. And he has a blog site called Sapienship, which I would suggest everybody should visit, and which he talks about situations very similar to what we are facing now. Technological disruption, ecological collapse, and of course he speaks about nuclear threat. And I think we can replace nuclear threat by the threat that we are facing now in COVID. And he came out with this, sorry, is the slide visible to y'all? Because it's,
Yeah, it's quite clear.
okay. And then he put out these 4 or 5 things, which I have extrapolated to our specialty. Many of the things that we need not worry about, the decisions are going to be taken by government. But there are some issues that we can deal with, and we should act quickly and decisively. And I have extrapolated to what we can do this for our specialty. And then said that the decisions we take as a specialty, we have to collectively take some decisions now that will shape our world. And that will answer partly your question, how it will affect the economics and politics and the culture of our specialty. And whatever we do, we should do it very, very quickly, taking into account the long-term consequences, recognizing that change will always happen. And based on this, I think we need to move ahead. And I look back at something that I wrote about a decade ago. And the more I look at it, and I think, there is a lot in what was said then based on what we are facing now, that our social and political projections as professional associates, we need to meet public expectation, and we need to outrun the competition. That's going to be very, very important. And we've got to do it with the diversity that we can offer. And that will really depend on some of the actions that we can take now. Now, if we look at our specialty, we need to leverage our strengths. I have no doubt at all that there are some things that are within our specialty that are unique to us. Dentoalveolar surgery, implants, and oral pathology. Nobody's going to take that away from us. And so our dominance in orthognathic surgery, that is going to remain with us. Now, when we look at clefts, craniofacial trauma, and oral cancers, these are issues that we face and compete with, in the same pie that the other specialties go after. But can we effectively prove that our expertise in this region, our reconstructive abilities in this region, our understanding of this region, we can outrun the competition? And then as a result of that, push harder into gray areas that other specialties occupy. And I think this is something that we need to look at effectively now. We just can't say, sit back and say, we are good at this. If you say we are good at clefts or craniofacial, we've got to make it a point to prove that we do it better than everybody else. And so far, we have not been doing that. We have just been riding the wave and said, we are going to do it, but there's no necessarily prove that we're doing it better than anybody else. And for that, teamwork will be essential, and the skills that we offer each other. And I take three of us as an example. We worked together and our skills complemented each other. And I think it greatly benefited most of our patients. And I think there is going to be no substitute for teamwork as we go along in this. We will have to work as teams, and I will come back to that in a minute. And if Apple and Google can team up, there's no reason why we all can't team up. You know, two bitter rivals have got together, and this is something Sanjeev and I were discussing yesterday. You know, companies as diverse at it, you know, going at each other's necks, and they are teaming up now. We should be teaming up. We should be getting together and pushing ahead as a specialty. But as always, and I have faced this, all of us have faced it, we have weaknesses. And this is something that all competing specialties have tried to exploit, what our weaknesses have been. And somehow, you know, we have to justify that our training standards and our competence matches. And most important, are we able to convince our hospitals about the usefulness of having a permanent oral and maxillofacial team? All the more pertinent now than ever before. Robert Strauss, and this is a nice anecdote that he quotes in one of the things that he writes, "Over my dead body," he was the chief resident, and then he wanted to do a submandibular gland. And the ENT surgeon blocked the door of the operating room and said to Robert, "You will not do this submandibular gland. I will not let an OMF surgeon. It will only be over my dead body." And he pushed past him saying, "Sir, then you will have to choose the way you die." And he pushed past him and he went in and operated that submandibular gland. And he quoted that. And I think that was a point he was trying to make, that we cannot allow others, especially at this point in time, to dictate to us what we can do and what we can't do. And we have to build the capacities to do what we are claiming to be doing. And this again is a bit controversial because he says we have to choose between teeth and titanium and major oral and maxillofacial surgery. I think there's certainly a place. About 70 to 80% of our specialty is based on dental-alveolar work and implantology at this particular point in time. But if we have to push ahead, if we have to maintain relevance, I have no doubt at all that it will be maxillofacial and craniofacial that is going to make us relevant in these times of corona. Otherwise, we're just going to be relegated to an outpatient specialty rather than a hospital-based specialty. And that again, I think, again, teamwork is going to come into play. I want to quote Deepak here. So why is our training going to be important? And this is in the time of COVID. What is happening now? That when you are a qualified OMS in India, in the United States of America, this is what you have. Your value comes from the fact that you can incubate patients, you can do central lines and IV catheter, you can do tracheostomies, and you can do life support. In fact, you can virtually run a mini ICU, and that makes us as a specialty much more valuable than medical subspecialties like orthopedics and ophthalmology and perhaps dermatology. And we have to build value into this. And I think this is certainly food for thought, that we have to push into areas where we haven't been before. I think what will happen post-COVID is that the government is going to get its healthcare act together. And this is going to be, I think, like, you know, you will be glad to hear me say this, but I think the Kerala model is perhaps going to be followed all over the country. Healthcare will receive priority. And as healthcare receives priority, we have to be sure, and that is where our association is going to come in, that in healthcare programs like Ayushman Bharat or the state-sponsored health schemes, that OMS is included. And if we do not get included, because they say during the time of COVID, you are not an essential and you get brushed aside, when things get back to normal, we will not have a leg to stand on. So certainly a lot of work to be done here. And Ayushman Bharat, the insurance policies and everything have to include OMS as a frontline specialty. And of course, technically, we have to be prepared for this changing scenario. And that is the threat, that if we do not do it, if we do not do in time to come, we will be relegated to a non-essential service. And that is a threat that general dentistry is facing now. When you speak to our dental colleagues, I think it's going to be a long time before they even get back to their routine practices. So should we maintain a distinct identity from dentistry? And that is a pertinent point. Identity distinct from dentistry, a hospital-based specialty that in the times of COVID and beyond will have a relevance. And AOMSI as an association, as a governing body of all of us, will have to play a major role in fulfilling this for us. This is times beyond COVID. COVID will pass another month or two, and it will induce changes in the way we work. But we have to look beyond that. And the question I want to ask all of you, everybody has to introspect, are we ready for that time? And I'm thinking at just drop of a hat, we would say, no, we are not ready. But we've got to act to get together and move very, very fast. Sanjeev.
Yeah, Kishore, I mean, meanwhile, there has been quite a few questions. Now, this is not a question to you, but a clarification for the listeners. There has been a lot of questions on hydroxychloroquine. So just to reiterate that Kishore has very clearly clarified in the beginning that this is not a scientific presentation about what is good at this moment or what is not good at this moment to be taken. This presentation is totally a philosophical presentation on what we as surgeons feel and what are we going through, what is the situation that we are in, how do we handle the situation we are in. And I think that the policies regarding medications, the policy regarding use of PPEs, all this are probably regionally dictated, are probably dictated depending upon the susceptibility of the place to the virus or the situation the place is in at the moment, whether it is a hot spot or not. So these questions may be difficult to answer, but the other questions that probably, one of the questions that Kishore has been asked is, are we going to move or are we going to have a paradigm shift from having face-to-face meetings or face-to-face conferences to virtual meetings like this? For two reasons. One is both for the economic reason, and second is also for reasons beyond our control, where travel becomes a problem. Travel becomes difficult.
I think I have the answers to that question, Sanjeev, and as I move on, I'll be able to answer those. I have some thoughts on those which I will share.
So then, coming back to, so what are we looking at the future areas? You mentioned a lot about shirking away the staticness at the moment and becoming dynamic. So what are the future areas of growth that you see that we can actually develop in? What are the changes that we need to make at the moment to become relevant?
I think some changes are going to get accelerated. I have no doubt at all. And what you were just asking me was that the use of technology, just as we're speaking now, a conference like this would have been inconceivable, say a year or two ago, with such a large participation. I think the use of technology, teleconsultation, might become the norm rather than the exception. And I think, having said that, if technology does come in, the last point that I make there, that is overall going to, along with the PPEs, is going to add a huge capital cost to our treatment cost, but for us as well as for the patient. I was talking to a dentist friend this afternoon, and he reckons that using a new PPE between him, the patient's assistant, the masks, his assistant, and whoever else that comes into that room would add about 1,500 rupees for each patient that walked into his outpatient department.
Kishore,
And that
Kita
is
here.
yeah,
Kishore, can I
yeah.
interrupt you? So there is, in relation to what you said just now, there is a very interesting question from Deepak. I'll read it out to you.
Yeah.
Can you hear me?
Yeah.
I have a question for Kishore. There is an economic theory. Cheaters always prosper. If everyone in town shuts down, except for you, you will get access to PPE as others aren't ordering it as they're closed and trying to limit expense. And you will work like gangbusters as you are the only game in town. I have every confidence this will start happening. And I think the only way around this is shaming the cheater. What are your thoughts?
Cheaters never prosper.
Right.
I only
So
have
you don't.
you can get off fooling some of the people some at a time, but you can't fool all the people all the time. I wouldn't take that as a very serious threat, because I think we have to do what is ethical and what is right.
Deepak, are you on? Deepak?
Yeah,
Is
I am
Deepak's
on.
mic on? Deepak, you want to counter that?
I'm sure there will be some people countering that, but you know, in course of time, this will even out. And I think we, irrespective of that, we have to go on ethically. And I was just saying the use of technology, you know, get your patients more often than not to, you know, if you can enable a teleconsultation so that when he comes to you, he comes with all the relevant investigations, comes with all the radiographs and scans. So if it is an outpatient treatment, you can perform it the day he came, or the first interaction could be very short, and then you could go on to a more detailed treatment. Shorten the number of visits. The post-operative visits, I mean, simple things like if you did a dentalveolar procedure or an implant, even if you put in resorbable sutures as against something that the patient had to come and remove a week later, he could consult you on a screen like we are now, and he need not come back to have his suture removed, and you and the patient have another unnecessary expense. I think we've got to think out of the box and think of simple ways and making things more convenient for us and our patients. And as I said,
Kishore,
the dentist
one more questions. Sorry, Kishore, one more question on teleconsultation. Are these medical legally sound as of now, or will it stay like that afterwards?
I would suspect there's no reason for it to be medical legally unsound. I see George Paul there. I don't know if you can bring him to answer that question, because I cannot answer on the legality of it, but I cannot see any reason.
Can we get Georgie on the screen, please?
Yes,
can we unmute his...
Yes, I will unmute him.
You can answer that question, and then I will go on to a few more thoughts on this.
Please, Kishore.
George can come in now.
Yeah, I think there was a Supreme Court ruling a few months ago, which said that WhatsApp and other platforms couldn't be used for prescriptions. But I think they've turned it around completely, because I think the MCA came out with a white paper saying that you can actually use teleconferencing to consult and prescribe and things like that. So I think we are moving, I mean, I think according to the times, we're moving positively. I think it's allowed now. That's what I get.
Okay.
So, Kita,
Yeah.
Kita, I just want to interject at this moment. There has been two questions actually quite relevant to what Kishore has been talking about regarding the economic impact. Now, one question is actually incidentally from the UK regarding the change in the kind of practice where microvascular used to be the norm. It has shifted to the use of pedicle flaps, etc. And the second question is more, some of the terminologies I do not understand, but it is more on whether we would start using bone grafts instead of more expensive membranes, etc. when we use implants. So basically, I think the question is about the ethical issue concerned here. I mean, are we going to be, under treating the patient because of this crisis, or are we just? I mean, are we justified in doing that, Kishore?
I must admit, I did not get that question, or at least the import of that question fully.
No, see, what they're talking about is where they could do a free flap, they have shifted to doing pedicle flaps. So where a patient deserved a free flap, they have started doing pedicle flaps. Similarly, where a patient, for example, a patient could get a bone plate for an open reduction internal fixation of the mandible, they would settle for a more non-invasive procedure such as intermaxillary fixation, etc. So are we ethically right in doing so at this moment of time? Are we going to be excused?
I think compromising the quality of care you give your patient is not acceptable under any circumstances, if you ask me. Whatever the circumstances, the patient has to get the best possible care. If I went in with a similar malady and knowing what I know about what is available for that particular malady, that is the standard of care I would expect that we should be giving a patient. Nothing less than that. I don't think we can compromise on that. If a microvascular flap is indicated and we put a recon plate or compromise by putting a free bone graft, I don't think we're doing a great service to that patient.
Has anybody, has Georgie or Kita got a different opinion?
No, I agree with what Kishore is saying.
I think, if I may, the AOCMF has actually come out with the guidelines which said that whenever possible, you could resort to close reduction of fractures if it's possible to treat it the same way as with an open reduction. I saw the AOCMF guidelines. So.
Yeah.
Right.
Which is actually incidentally being adopted by the International Association of Maxillofacial Surgeons as well, the AOCMF guidelines, and it'll be out very soon. So yeah, I think
Sanjeev, in this, I think you have to be human in this and say, irrespective of guidelines, like I said, if you were to be treated yourself or a relative had to be treated, what in your opinion would be the best treatment? That is what you should give your patient. It can't be anything less. And if a patient can get rehabilitated with an open reduction and get back to work in 2 or 3 days, you're doing them a much greater service than keeping him confined for 6 or 8 weeks with intermaxillary fixation or whatever else that you're going to do. I mean, my views on that are pretty strong. I think we should give them the best treatment possible.
Okay. Interestingly, I'm going to play the devil's advocate here again. What about there was a particular country, I'm not mentioning the name, which also went online deciding that if a person had too many comorbids, they would not be given the benefit of survival with the best of facilities. So, I mean, your opinion would be the same regarding that as well, I assume.
If the facilities are available, the treatment should be offered.
Okay.
And if I think the patient should be obviously wanting that. The patient should have a fully informed consent that this is what your chances are. Some patients may choose not to take the treatment, but the option has to rest with the patient. You can't take that right away from anybody.
Thanks, Kishore.
And again, like I was saying, I think PPEs will add to the cost of treatment. And again, I don't want to go into a PPE protocol, how to scrub your chair, how to keep your room in order, what your staff has to wear. No, those protocols are going to be defined by whoever, by associations, by authorities that are enforced. But it's not for me. But I think PPEs are going to be routine. And somebody asked me again this morning, he's saying, can I wear a PPE and examine 10 or 12 patients with the same PPE just by changing my gloves? Now, I think if you say, yes, you are protecting yourself when you do that, but are you doing your patient a good by that? If there is any secretions, any body fluids on your PPE, the subsequent patients that you examine, are you putting them at risk? So should you be changing PPEs for every patient that you see? I would say ethically, the answer is yes. Practically, is it possible? I don't know. Should PPEs be the kind that are washable and recirculated? Maybe in our economic circumstances, we can do that. I have no answers to that. But again, in all these circumstances, irrespective of adding cost to the patient and to yourself, you have to do what is best for that patient. And we have lived through the age of HIV in the early 80s. Some of us who were working in the early 80s, I think fortunately or unfortunately at that time, we didn't have access to so much information. There was no overload of information. We took in some universal precautions and we went on. No, we got on with it. And when a patient was HIV positive, we were dressed like how these PPEs are now. Rest of the patients were treated like very, very normal, like how we were doing until recently. That is going to be changed. That is going to be a paradigm shift. I don't see any other way around it. And we should be doing it. Universal precautions everywhere. One of the most, I think a very, very famous oral and maxillofacial surgeon, I don't want to name him, he's written a great textbook, died of hepatitis. And, post-transplant issues with hepatitis. And I think, we have been lax in things that could really affect us. And now COVID has opened our eyes and we are looking at universal precautions. And I think this should carry on for a lifetime, not just until somebody says, oh, COVID is gone now, you can go back to square one. I hope we don't go back to square one. We have to adopt universal measures. As a specialty, as a profession, all doctors have to do it. I hope that is the message that some of us will take away from here today.
Kishore,
yeah,
there are a lot of questions that have started pouring in. Yeah. I've just filtered them down to two questions. One is, which I thought would be quite relevant. One is whether, like we have routine screening for all our pre-surgical patients, would antibodies and COVID tests become one such screening screening requirement in future? And the second question is whether we will, is there any ways to cut short on our material expenses? And is it ethical? But I think that you have already answered. So
I think as far as I'm concerned, from what I can gauge what we are now, if we do not take the option of universal precautions, we are doing ourselves and our patients a great disservice. COVID or no COVID, HIV or no HIV, hepatitis or no hepatitis. I think we owe it to our patients, ourselves, and what we can take home to our families. Universal precautions are going to be the norm. And if we don't do it, I think it will be border on something doing very, very unethical and something very, very wrong. We should be careful. That would be my answer to this. There cannot be a compromise on universal precautions. However, they may be defined. We may cut down on some of the requirements. But if we cut down to a minimum standard that is required, the ceiling, we establish the ceiling, not the floor, and stick to that, we should go on with that.
Right, let's move on, Kishore then. Kishore.
This is a picture of Deepak. And I was, he sent it to me with this wearing his first PPE. And the only remark I have is that you look like you're wearing a spacesuit. Number two, it must be very cumbersome because they're saying, some of them are saying, we need to wear 2 sets of gloves when you do this. I'm certain manual dexterity would be a problem. If we did this all the time, a teleconsult and dressed like this when your patient came in, he wouldn't have the foggiest idea who he was seeing or who he was dealing with. I think we're cutting out a bit of the human interaction as a result. I don't know any way around it, but it is going to happen. He sees you on a television screen or a computer screen, and the next time he sees you like this. And I can imagine if you're treating a child, if you were a child specialist, a pediatric dentist, if you approach a child like this, I think you would have that child bolting out of the door before you know it. I don't know how it's going to work. But nevertheless, it's a necessity. And I don't know how we can overcome this. Can I just?
Kishore, while you're on muting there,
Yes, I know. I'm
and
trying to
shooing
do
away
that.
your dog.
You know what's happening there, isn't it?
Yeah,
So
yeah.
it's time
Okay,
for
it's
his
done.
walk.
It's done.
I just want to give you an insight on what this is a PAPR. It's one of those things that I have to wear only to see COVID positive patients.
Okay.
And your earlier comment about how cheaters will not prosper is correct, except my patients also cheat. So we have a policy now that only true emergencies are to be seen under any
Absolutely.
circumstance.
Yeah. That's the case everywhere now, isn't it?
Right. So we are now doing telemedicine triages and screening patients to make sure they do have a true emergency. Is your fracture just a ZMC that can wait forever, or a nasal fracture that's not obstructing you, or do you truly have jaw swellings? But this particular, this PAPR
Yeah.
makes a lot of noise because there is an air filter inside it and a fan that keeps running.
Okay.
So more than just the examination glove and its dexterity, it takes like 5 minutes to put on and longer to take off.
Yeah.
You can't hear anything once you wear this.
Yes, I can imagine that. Yeah.
So when the patient kind of, tries to tell you something, you're like, and you're supposed to wipe it down and reuse it every time. And so the concept of, am I using the same PAPR? And these things are about $300 a piece.
So they are expensive.
They are.
So similarly, I mean, I had pictures of the PPEs that have come out here. They look very similar, except there's no covering right around the head. And they are expensive. Like I said, it costs about 1,500 to 1,800 rupees, just the cost for, equipping yourself enough to see one patient, yourself protecting a patient, protecting your assistant, and a minimal requirement for the patient's assistant. So that's a significant cost as far as India is concerned. I mean, I don't think a public health service can bear that kind of a cost in our circumstances. And if you can load that kind of a cost on every patient that you see, every time you see them, that's again a very significant cost.
We only have 3 of these for the entire unit, and we use them only sparingly. The one that I did manage to find was from a hardware store for construction equipment. It's the same grade, and now they're sold out because everybody's trying to buy them.
Okay. Thanks for that, Deepak. But nevertheless, that doesn't make a very pretty sight. That's all I want to say. So, I think something that I wear now, wearables, I mean, I'm just kind of thinking, is technology going to affect us? I think it will. Already, a simple wearable like this can transmit so much information to your phone, and from there to your hospital or your cardiologist. So I think there is going to be a big paradigm shift in the way wearable devices are going to be used to monitor our patients. Now, we are already seeing wearable devices which connect to an electrode that's placed in the retina of patients, who are visually impaired, helps them to see, blood pressure monitors, glucose monitors. And I think that's going to extend to, I mean, obviously, oxygen monitoring is going to be a very, very easy thing. And I just look at, trying to say, is this going to change the way that we can look at patients in terms of, can they go home earlier? Can you monitor their vitals when they're away from you? That's number one. Number two, many of us are getting into treatment of, say, obstructive sleep apnea. Can wearables, in the long run, not immediately, in the long run, substitute for many of those very, very difficult sleep studies that we put our patients through? If I had to do a sleep study in a hospital, I can guarantee you I won't fall asleep in a hospital. But if I was going to do that sleep study in the comfort of my home with a simple gadget like this, which already monitors a fair bit of your sleep patterns, with a little more added to it, why can't wearable gadgets help us more in looking after our patients? And I think technology, apart from telemedicine, these are some of the things that are going to help us. Vital signs of patients being transmitted directly to us, so we can decide, when they need to come in or not come in. It's just a bit of conjecture here, but it's a very interesting concept that it might come in. And this, Deepak, you and I speak about this very often, serendipity. Serendipity, I think we are going to be forced down some of these roads or accelerated to find some of these solutions, to find non-surgical solutions to some of our problems. Serendipity, we find something that incidentally helps us in a very pleasant way to get a better result elsewhere. Mice with craniofacial synostosis treated with chemotherapy for intrauterine carcinoma exhibited that all the signs of synostosis disappeared. Craniofacial synostosis and Treacher-Collins syndrome disappeared. If you look at the mice in the middle, having traits of that, but mice who received that had no features of any bony deformity, even when you saw the skulls. You can see where the arrows are marked. And these are directions in which we are going to accelerate ourselves going. And I do not know whether with our current set of skills, whether we are going to be able to push in these directions. But when these solutions emerge, I think our specialty should adopt measures and train ourselves enough that we should not be left behind when these solutions are found. Gene sequencing for personalized cancer treatment. Certainly, that's going to make a big difference. And this one in the Lancet said, artificial intelligence is probably going to be better than us at diagnosing disease. So can we be left behind when all this happens? My son, who's an architect, had put me through some kind of a virtual reality screen a few months ago. And I was amazed at what it could do. It was amazing. It was like actually being there. So I think we're going to see, just trying to develop an analogy, we are going to see, say, how can we have less contact with the patient? I think trying to make a very simple analogy, when you do implants, for instance, now we're getting these beautiful stents which you can just place in patient's mouth and they guide us as to where the drill should go and we just put the implants in. Makes things very easy. I think it's going to take it several steps further, that we are going to, in the end, be able to do some kind of augmented virtual reality and without actually, perhaps in a non-contact way, perform many of these procedures with a great deal of accuracy and much less complications and discomfort to our patients. It might happen. It is not beyond the realm of possibility from what is happening in other fields. It might mean that we have to bring in different skills, work with different sets of people. These are the paradigm shifts that something like COVID or a crisis will push us into. We'll need to work with engineers, with computer engineers, with people who are good in liberal arts and people who are good in aesthetics and with manual dexterity. Somebody who's ambidextrous may be able to do something better than us in designing something like this. I think paradigm shifts will come and we've got to take the positives out of this and say, yes, this is a big blip in the horizon for us. COVID is a big blip. But if you want to think positives, full positives, we've got to look at technology and say, maybe technology will offer us solutions which we didn't think of and accelerate our way to find them. Sanjeev?
Hey.
Yeah. I think there was some interesting question as well regarding, you were mentioning about the dynamic changes in the way we practice, about how much of technology is coming in. So do you think robotic surgery would really would catch on in a big way?
I think to an extent it will, Sanjeev. Just what, that simple slide that I showed you. I think robotics, definitely assisted by a certain level of skill that we can impart into that robotic system. I think it's not going to be essentially say the robot can do everything for you, but your skill can be translated into something that a robot can perform more efficiently than your hands would. Accessibility, for instance, as far as I know, accessibility can improve with a robotic surgery. So why not? Yes, I think it will happen. And we need to push in that direction. My point is not the movement towards, I don't think we should have any objection to moving towards robotics, moving towards artificial intelligence, or moving towards any of these systems. That cannot be our objection. Our objection and scare should be that in the move to that, we should not get left behind and relegated to something that they can do without. We have to be a part of that movement. And crises force humanity to look for solutions, and we have to be a part of that solution.
So when you say we have to be a part of the solution, as a professional association that we are, I mean, do you have any suggestions on both in terms of the technological advances and in terms of academic pursuit and skill set pursuit?
I think essentially, I mean, I'll talk to, I think we'll allude to that again in a little while. But this specialty or no specialty, no medical surgical specialty can be an island anymore. It has to evolve. It has to work with people who can provide technology and information from all walks of life. It cannot remain isolated and saying we will grow purely as maxillofacial surgeons. It is not going to be possible. Even when you want to deal with COVID, infectious disease, we will not have the bandwidth to do that. We will have to be based on recommendations of a lot of the people. Just in that respect, I think we will have to incorporate a lot more skill sets, a lot more of other professions within us to move ahead on this. It's not going to be possible.
Could I make a little comment about your idea about robotics?
Yeah.
So this is, as we adapt technology, it's important for us to realize and come to terms with the fact that it is a bridge that allows traffic both ways.
Yeah.
And what I mean by that is, so there is what you talked about earlier about digital dentistry and all that. There is this nice equipment already available called XNAV, which is a robotic GPS assisted implant placement robot.
Yeah.
And there are more and more general dentists that are buying these that don't require a surgeon now to place an implant in a fairly straightforward manner. Similar to that, the Da Vinci system that a lot of us are used to, they are now training interventional radiologists and nephrologists to do CT guided procedures to either drain abscesses or drain chyle formation or whatever you name it. So there is going to be an intrusion of non-specialists into specialties as technology improves. So we should come to terms with that too when we embrace technology.
Yeah, exactly. And I think when we embrace technology and the advancement that technology brings in, we need to be a part of that process, or we end up being on the losing side of that. That the patient gains from it. Let's all put at the end of it. The patient gains from it, but we can also gain provided we are a part of that technological advance.
Agree.
Yeah. In the end, the patient is the most important factor. If he gets the best out of every emerging scenario, it's a job well done. We shouldn't be complaining, but as a specialty, we need to move on. And I mean, I look at it and say, what was happening 30 years ago to now? There's a sea change in it. So we can't complain that our specialty has not moved on. I think we have embraced technology as good as anybody else. But I always say we could be better and we need to keep moving.
Shall we move on, Kishore?
Yes.
Right. So that was a question that Sanjeev asked you earlier.
Yeah.
You can now go ahead.
I think, like I said, we have made a great start. The viral lectures, it's the number of people taking part is incredible. And I think the skill sets we just spoke about, I think we need to be proactive and include the skill sets all the time. The thing that I worry about, and I alluded to this earlier, and when you talk of Ayushman Bharat and insurance services, I think one of the tasks that the association has to do, and that's a great service that it will do to its members and to the profession, is to ensure that OMS takes a very, very prominent place in the government scheme of things. Especially, I think COVID is going to alter the scenario into what is essential and what is non-essential. And by chance, if we get relegated to non-essential, I wouldn't say, probably the word is not right, but if we get relegated to non-essential, it will be very difficult to fight back and say that we are a frontline specialty. We have to be a frontline specialty. That will be the job of the association. It cannot be up to an individual sitting in Bangalore or Delhi or Mumbai to do that. We have to do that collectively. And with that, we have to ensure that our expanded skills become a part of the teaching curriculum. We have discussed that before. But everything that we do should be officially within our curriculum, and we should ensure that those of us that do it are more than capable of doing it. When we say, for instance, we always say that, oh, we do trauma better than plastic surgeons, or we do trauma better than ENT surgeons. Maybe, but we haven't really gone out and done enough of an analysis on the work that we have done to say that we are better. We haven't done that, and it's time to start doing that. We've got to go to the treetops, get to the rooftops and shout that, hey, when we do this, you got to come to us because we do it better than other people. And that is, again, something the association has to drive its members to do. We have to do it as individuals. We may be doing a great job, but we have to prove and seem to be doing better than the other specialties. And I think, you know, unless we do that, we will not have a claim to say that we should be given the upper hand in some of these services. Let us strive to do that. And somebody asked me about conferences. Yes, certainly. I think based on the success of this, we need to reduce the number of conferences. That reduces our financial and travel burdens, maybe just one annual meeting. And I think the way this is being conducted, for instance, you don't need massive venues to hold a meeting where everybody congregates every more. You can have multiple halls, people spaced out with social distancing or whatever you want to call it, relay to the rooms. So you have a minimal number of people in the room, you know, people spread all over watching the lecture from where they want, and then you can have great social events where everybody meets. I don't think we can do away with meetings. I know George Paul, I know so many other people, I know Neelam Andrade, I know many other people because we meet at conferences. And if you do away that human interaction, we're not going to be doing that anymore. So I dare say we cannot do away with conferences. We need them, and we need them to interact. We need them to know each other and move forward as a body. But certainly with technology, we can optimize the way we can do conferences. And COVID again is pushing us to that, you know, and push down the financial burden for our members and yet optimize the use of technology and the transfer of knowledge. I think if there's somebody from the association here, I would like them to comment on this, because I would really like to say, can you lobby and ensure that we can push ahead for this?
Well, you
Praveen?
have the president and the secretary.
Yes. Praveen, can you get President and President-elect Dr. Manjunath Rai at this point of time, please?
Yes, I'm doing it.
Yeah, please.
Veera sir is
And yes, Veera sir, can you answer Kishore sir, please?
Manju sir is also in.
Okay, I must tell at this point of time, Dr. Veera sir was getting impatient, like when the midterm conference got cancelled, and he said we need to do something for the members. And when we discussed about webinar, he was overexcited. And when he heard Kishore sir is giving this lecture, Veera sir, do you want to describe what you told me?
Hello, Pritam.
Yeah, Manju, I can hear you. You can answer Kishore sir, please, as a
Yeah,
president-elect.
Okay. Yeah, Veera is here. Go on.
Kishore, can you come again? That it wasn't clear, that question.
I just said that, you know, the association needs to do a lot for us to keep our nose ahead of business. When the government tries to define what is essential and not as non-essential, you have to ensure as an association that all of us are protected to the extent that we are included in a list of essential services, and that OMS is recognized as one of those services that are needed and will be listed in services provided by Ayushman Bharat and perhaps all the government and private insurance companies.
Yes, definitely we will do it, Kishore. We are working on it. But of course, at this current situation, we cannot do. Once all this COVID crisis is over, we will definitely lobby with the people and we will do it.
No, the point I'm making is that the COVID crisis is going to force the government to define what is essential and non-essential. And the time to act is now. You know, we've got to do the groundwork and define what is essential and why we are essential at a useful service for the
Yeah, I
general
get your
public.
point. Since we are the only people among the dental specialties working in the hospital along with the other specialists, and all these essential works like trauma and everything we are involved. So we can make the government understand that a step ahead of the other specialty and the necessity of us in involving them in Ayushman.
Yeah, I think the paperwork that will be involved will be immense, and we need to do it.
We need to lobby. We need your support, like big people like you.
I'm big only in size now, Veera.
So just to add on to that particular thing, can you hear me, sir?
Yes, yes.
Yeah, sir, I totally agree with you. The reason what you said is like, if something should be matter now, because if you, right now, if you're not active, as I said, we are going to become a non-essential. Now, most of the places, where people are part of the dental colleges, it's maxillofacial surgery in every college is being active to some extent. I think what we should do from the association is that we should give them, write to the government and saying that, we have this many large amount of members who are there in every corner of India. And at least this thing would be there. I mean, whether they will consider it later or not, whenever there is an emergency, presently, we are all going, but the government is not aware of it. So we, from the association level, should write to them and say that we have such a strong association and we have representation all over India, and there are emergencies related to, let's say, infection or airway. We are ready. We should write to them, and whenever required, we should provide them the people or the numbers or the names of the members and addresses to those things.
I think I went a little beyond that. What I said is that as a specialty, you've got to make a case that on all the things that we do, we are qualified to do them. We do them better than many other people. And that when the government decides that these are essential services, that OMS will be on top of that list. And that is going to be the post-COVID scenario. The work that is required is going to be lobbying. Just, it's a lot of lobbying that will be required, like we have never done before. And there will be pushback. There will be pushback from other specialties because they demand the same space that a post-COVID scenario will ask of it. They will all push for the share of the same pie.
Right.
And that is what we have to demand, that as our pie, our share shouldn't get smaller and smaller and we are left with nothing. We need to push in such a way that we get the largest share of the pie because we say we are the best people to deal with it.
We will definitely do, Kishore.
Yeah,
We'll take this advice from you. Thank you.
Yeah.
I think there was a very interesting question about whether there will be a shift in private practice from the current setting to hospital setting, whether people will prefer as a rule to come to hospitals or they will be happy as it is to go to the clinics. I would think in the contrary, but what is your opinion?
You asking me?
Yeah.
I think we should ensure that the clinics go on. I think it's not just for maxillofacial where we speak about people who do a lot of dental-alveolar work and implants, but it should apply perhaps to general dentistry as well, because the rules that apply to general dentistry will apply to office-based maxillofacial procedures as well. And I think there is a sufficiently large number there of people who can put protocols and ensure that goes on. I think as much as I was against it in the past of diversifying from dental alveolar and implantology, into major maxillofacial work, COVID is forcing that change. We will have to ensure that our colleagues who rely on outpatient-based work do not suffer. And they will not, provided, I think, they take the right precautions along with the rest of the population of general dentistry. I think they will survive. But on the other hand, those of us who are going to be essentially hospital-based will face an entirely different set of problems. What we have just defined in trying to say, are you an essential or a non-essential service?
Right.
And I think, you know, we have to now look at these two distinctly. The association will have to concentrate on the broad range of major procedures that we do and make sure that we are not excluded from it. All those of us who do implants and dental alveolar work will continue doing it because our dental colleagues are keen that it continues, the clinics will continue, and we will be absorbed into that system. A lot of us work with general dental practitioners. And, you know, when we adopt those standards and those standards are adopted by dentists as well, we all are going to benefit from that. I'm sure a patient coming in is going to be reasonably well informed on the precautions required. You know, if he can do a teleconsult and then come in fully prepared with all the investigation, you can reduce costs even at a dental practice level. But simple things like I alluded to earlier, you know, do a small procedure, use resorbable sutures, then do a teleconsult and bring that patient in only if needed. You reduce the burden on yourself and the patient. It can happen at the outpatient level, but it's going to be a whole new ball game when we talk about hospital-based maxillofacial surgery. Does that answer your question?
Could I suggest something along those terms? I think the importance of an outpatient procedure center like everyday clinics shouldn't be minimized, because what it does is it prevents and prohibits people from getting to a point where they need to go into a hospital where they're probably exposed more and more to COVID itself. So a simple thing as an extraction done in time prevents a Ludwig's angina, right? Like, so that a bigger infection can be completely thwarted if you had your offices open and you did a simple procedure on an outpatient basis.
Absolutely, I agree with that. And you know, I'm all the time I'm trying to stress this is COVID and beyond. COVID will pass in another few months. Hopefully, it will pass. But we need to get our act together for the post-COVID scenario all the time.
I think you can go on, Kishore.
Okay. So I think we've had a sufficient discussion on that, have we?
Yeah.
Yeah, let's move on.
Kita.
Yeah. So this is something one of the very important questions that I wanted to pose to Kishore, and I was also a little hesitant to ask him because here I was spreading into a personal territory. But for those of you who know him, he is a real warrior, and it's impossible for any one of us here to have encountered situations in their personal life which could have been less daunting than it was for Kishore. So it's so important that when you have a sudden trauma in your life, be it something that is affecting the public health or be it something that's affecting your personal health or your financial status, whatever it may be, how do you cope with that? Are there any mechanisms for that, Kishore? This is something only you can answer amongst us.
Well, I think, you know, support of family and friends was foremost in that. That's number one. And I've written about this. Some of you may have read what I have written. And my belief in this was that when I accepted to be treated for all the things that were going wrong, that I would only go with the best available treatment that was recommended by the treating physicians or surgeons. And, you know, I took their advice and followed every bit of their advice. And I think I personally, knowing what I knew, could research a bit of the evidence and say that the treatment that I was receiving was the best. And I think to an extent, as far as treatment went, for me, it provided the best possible option and perhaps the best possible result. How did I cope? Well, you know what you all have gone through in the last 2 or 3 weeks in terms of lockdowns. 3 weeks of lockdown with no contact with the outside world. Just imagine that happening 6 or 7 times to you, many times over. That's what happened. You know, many a times your world locked down. You had no way of knowing what was going on outside, and you had no way of going on what was going on inside, and that was even more daunting. But nevertheless, you coped because you had full faith in the people who treated you, and that you always had family and friends who backed you. And I must again look at this and say, extrapolate it to the people I worked with. And I particularly want to point to you, Sanjeev, Kita, Kumar, Preetham, and everybody else who was there. At no point was I more thankful that we were working as a team than I was at that particular point in time. Because many a time it so happened that I had to stop work on a particular day. You know, it just came to a standstill, and yet I could walk away. Might as well have been hit by a truck going across the road, and yet every patient was looked after. Nothing happened, and my patients received the best, and yet a part of my income to continue. I think that was the advantage of teamwork and having faith in the people you worked with. It made a huge difference to me, and I think it made a huge difference to my well-being, knowing that everything that I had worked so hard for was being taken care of. It was really important for me. And I'm talking purely from a professional standpoint. I think the hard times make you tougher. There is no saying that. You have to learn from it. It has to make you tougher. And it did make me tougher, but it also made me realize, you know, Kita, I came back to work several times. And many a times I used to tell you all, you know, I'm not enjoying this as much as I was before. And yet I would see work was going on. And in those years when, you know, we were interspersed with many of these problems, and I look at it as many COVIDs happening to me. And let me put it that way. Many COVIDs happening times over.
Right.
And when I came back, I saw not only was work going on, but numbers had increased, patients were happy. When I came back, the patients who knew me were happy to see me. That was very heartening for me. But the greatest realization for me and the greatest sense of relief, honestly, was knowing that I was not indispensable. Because there were people who took over your work and made it even better than what you could. I mean, you know, in the sense that I always say that when you work, anything that you do, you plant trees under whose shade you may never sit. And I think we should all do that. Today, I mean, I look back, I consult, we meet each other, we speak about our practice and the way it has grown. I'm very proud of it. I still feel very much a part of it, although I don't want to get my fee. You wouldn't put a gun to my head, I wouldn't come back there. I'm enjoying life now, doing what I'm doing, you know. Like I said, I have developed different skills. As you know, I do things, I don't know, maybe bordering on illegality.
Kishore, Kishore, just going a little bit aside, can you tell this audience why hunter-gatherer became agriculturists? Can you tell that story? Why the hunter-gatherers became agriculturists? This is something everybody needs to hear.
That is a true hypothesis. You know, it's a true story. It's a hypothesis, but it's very true.
Yeah.
The reason
please
I
tell
want
them.
to say this today, most of you, my skills of reading, and I like to use my hand. Today one of my passions is making beer, and my knowledge of making beer is transferring to many small breweries in Bangalore. I make recipes and give some of the recipes, beer recipes that I use have gone to microbreweries in Bangalore. So, you know, that's something I'm enjoying now. It's totally on a non-commercial basis. And I like it because in the process of making those recipes, I get to drink a lot of beer. Now, when we go back to what Kita was asking me, it's just an interesting story. It's nothing connected, but how necessity drives man to do things. That man was essentially a hunter-gatherer. You know, he had plenty to eat. He could eat a mammoth, he could hunt a whale, he could hunt hundreds of things and then pick it up. He had no shortage of food. And man found alcohol in nature. He found it fermenting as honey, some grains fallen in a pot, and then he left them for a few days and they were fermenting. And he found that, you know, he was getting alcohol. But the hunter gathering that he did not allow him to make alcohol on his own. So man, as a result, started growing grain, barley, wheat, and rice essentially, which he found fermenting in the wild. He turned to agriculture only to make alcohol. And that was the genesis of agriculture. So when man is pushed to desperation, he will bring out new ideas and he will turn innovative. And if trying to extrapolate that, Kita, if we are being pushed to a corner by COVID, I think that could be the agriculturists in coming out, pushing us to innovate to make beer. We will learn new things because COVID pushes us to learn new things and adopt new ways.
Kishore, I have a question then. So at the next meeting in Mangalore, can you open a booth for your beer? We'll give it to you free of cost, the booth space. Come on, Kishore, come on.
I can't, it's illegal.
Booth space. Okay.
I can teach people how
to. We'll see if Manju can get you permission.
Yeah, we'll get you permission.
I can teach people how to make
demo.
It. And so,
you know, only for demo, not for sales.
Like COVID and everything else, this is a very cliched saying, but you know, life's not about how hard you can hit. It's how many you can take and still keep moving forward. And this is my guiding principle in life. You can get hit, you can get battered. You got to stand up and keep walking. You don't have to worry about hitting somebody else.
Yeah.
If you can absorb the hits and keep moving forward.
When you're talking about beer, Jimson wants to know how quickly you can make a bottle of beer.
We can make a keg of beer in about 10 days. It takes 10 days.
There's your answer, Jimson.
Yeah. And you can't do it by teleconference. That I can tell you. So
will the technology come in, you think? Send it through microfibers.
There are machines that do it, but you know. So there we are.
Right. Let's move on to the last one, Kishore. So we are getting a lot of questions here regarding training and you know, scope of practice and stuff like that, which probably is not part of the seminar. But what would be your advice to a young and struggling max-fac surgeon? Or what lessons, in a nutshell, can he learn or she learn from this?
I think the times of COVID are very testing. If the times of COVID are very, very testing for all of us.
Kishore, can you hear me?
Yes, I can. Can you hear me?
Yeah,
Am I audible?
We can hear you.
Okay, I think the times of COVID are very, very testing, and more so for some of our young colleagues in this nation, on all over the world. And I think it's not just us suffering; the whole nation is suffering. You know, the daily wage workers, the people who do small businesses. So you know, I think we are not alone in this. Young and old, people who teach, people who work as office boys, you know, who are less fortunate than us are probably suffering a lot more. So I think, you know, when we empathize with the rest of the country, I just want to tell people this, that, you know, you have access to information, to all the young people there. And I don't want this to sound very harsh. You have access to information like you do in these lectures. You have access to information on the net. You have access to journals. You have several web-based seminars that are happening all around the world. And you got to make use of this time to develop new skills, get more knowledge, get fitter, and develop a new way of thinking. And if you do that, you'll come out of this very, very strong. And if you can't, I think you just show that, you know, you didn't have the willingness to adapt and learn during this very difficult time. You have to learn from adversity. If humans can learn from adversity, you will progress. Adversity has many sweet uses. And I think, if you can make use of adversity to progress, that would be even better. And I think you need to take a more worldly view of things rather than saying, oh, this is affecting me. And I think this is really for everybody. Our work should be for larger public good. We need to do what is good for the country, what is good for our patients. And sometimes when you're sick, you're having a flu, there is no harm in taking a day off. In fact, you should take a day off and not go to the hospital and try and give the flu to so many other people and incapacitate anyone. Taking time off, learn continuously. And I think, yes, we need to make a case as individuals, as people, as an association, that doctors need to be paid better. I think one thing that emerges from this scenario is that healthcare workers, including all of us, are going to get a recognition that is due from the public and from the government. And we are going to be recognized and we are going to be paid better. Our emoluments are going to be increased. And it is one of the spin-offs of this crisis that people will see us as being as useful as many other walks of life. So learn, I think, make the best use of it, and certainly less materialistic and healthier lifestyle. And definitely point number 8 there. And this is something I have learned all my life. You have to be the ant and not the grasshopper. Right from the time you're young, you start setting aside for a rainy day. COVID will pass. That's all I can tell you. It may take a month. It may take 2. It may take 3. There will be a new life. There will be new ways. And there will be better things that emerge out of it. You're not going to come out of this worse off. You will, at the end of it, come out of this better than what you are now. And use this time. Look beyond your profession. Pick up sports, pick up hobbies, pick up reading. It will hold you in good stead. When you start thinking laterally about how the rest of the world does things and bring those things into your profession, you are going to be a better professional. That is something that I've learned over a period of time. If you know only surgery, only maxillofacial surgery, only dentistry, that is not enough. You've got to learn a lot more. You've got to broaden your horizon. That will prepare us not just to live better, but I think when the world changes, we spoke about technology coming in, you will be able to adapt to technology and make a living out of it. I think these are the advice that I can give you. As somebody who's been there and done that several times, this is my piece of advice for you. Nothing is never as bleak as it seems. It always gets better.
That's
very inspirational. There has been a lot of questions regarding training, regarding the training pathway, regarding use of HCQs. I'm sorry we were unable to answer all those questions or pass on all those questions to the speaker because Kishore had requested that this is totally a non-technical talk. Like I said, I reiterate, I repeat, it is a non-technical talk on our situation, our mental situation during the times of COVID, and how we react and how we are, how our mental framework has been during the last couple of weeks and will be for the next couple of weeks and for the future, and what are the solutions that we have in front of us. I think he probably has some more things to say about it as we conclude.
Point number 9.
Sorry, is that another question you said, Peter? Is there something to say before?
Someone wants to go back and discuss the point number 9 once again. Can you go to the previous slide? Yeah. Point number 9.
Yeah. That's something I thought of myself, really. Content alone, but I think with what we have now, I think social distancing is not the correct word. It's physical distancing that we have. Look at all of us. We are sitting different parts of the country, different parts of the world. And like Deepak sitting here in Cincinnati, and he's right here in front of me. It's physical distancing. It's not social. You know, Deepak could be sitting right here next to me, and then we could be saying things to each other. So I don't know why they ever use that word social distancing. Wrong word. Physical distancing to prevent viral infections. I don't even want to talk about COVID. Physical distancing, I think, is a good thing. You know, when you're walking on the street, not slapping somebody on the back, going shoulder to shoulder, cheek to cheek with them. Great thing to do. Maintain your space. But yet that doesn't mean that we don't be in constant touch with each other. With the technology that is available, if we are not socially close to each other, that means we are doing something wrong. And yes, we will meet at meetings, we will have our gala dinners, there will be music, all that will come back. It's not going to be gone forever. But I think the way we all are going to get together and interact with each other is going to change, and that's going to be for the better. You know, we may not shake hands, but we're going to say namaste. Why not? Pretty good. We will move on. And I think, yeah, point number 9, I should have stressed on that. It's something I thought of. Social distancing. Let's not call it social distancing anymore. Physical distancing. Whatever it is, 6 feet across the universe, everything is fine, but we are socially never distant from each other. Can I move on?
Yep.
So I just need to conclude very soon because we've been at it. I think, you know, again, if those of you like to read, this is a book I read a few months ago, Tom Phillips, the history of how we effed it all up. And humans have really been screwing things up all the time. We've got it wrong, and yet we have survived as a species. COVID, whether it was man-made or whether it was an accident or whatever, we will survive it. I have no doubt that we will survive it. Humanity will conquer the mistakes that it makes. And you know, the person in that picture, and I say person, that is Lucy. You know.
So can you share your screen? So your screen is not shared.
I am sharing it.
It is actually.
I can see. I can see it.
It's shared.
Yeah.
Oh, is it? Maybe a problem with me.
Okay, so that person on the screen is Lucy. I mean, I say she's human. She was the first missing link, they say, in as humans evolved, found in Africa several in the 1960s. And I particularly bring up Lucy, you know, because Australopithecus afarensis, that is, she is the missing link that we found. The question is, why did we find only Lucy and not many else like her? We found only Lucy as the missing link. And the postulate is that when Lucy's skull was reassembled, her lower end of the femur was shattered. So they were all arboreal creatures. They would climb trees and wander around. And Lucy fell off a tree and broke her femur, and the rest wandered away. We don't know where. But Lucy died there, fossilized, and whatever we found her remains. And actually we found Lucy because humanity screwed up at that time. Then the first emerging human, we found Lucy because she screwed up. If she hadn't fallen off that tree, we would never have found Lucy. You know, that's the lesson I learned, that humans have been making mistakes all the time. And yet we evolved from Lucy to what we are today, Homo sapiens. You know, we've had Chernobyl, we have had world wars, we have had the plague, we have had smallpox, and yet here we are sitting thinking that COVID is going to destroy us. COVID will not destroy us. It doesn't have the capacity to destroy us. It will destroy you like life. If you let life destroy you, it will, but COVID will not destroy you. We will not allow it to be that to happen. So Lucy screwed up, lots of other things have screwed up, and yet we will move on. And as Harari says, when humans squabble, viruses double. But if we work together, you know, we can not only fight corona, but all future pathogens. I think there's a message in that, what he said. He says, You can only win battles if you do things collectively. And that's what we're doing here today. We are sitting, and I may or may not have said the right things to you, but if you go away and start thinking, I need to find a way out of this crisis. We need to find a way out of this crisis as an individual, with my family, with my association, and everybody that I know. We will survive this. This will just be a blip, and in 6 months' time, we will be working like normal again, in a better way, though. I hopefully in a better way, that when a crisis like this hits us, we will be fully prepared. I have no doubt that humanity will survive and will be prepared. And again, it's Easter, coronation. On Easter Day, somebody was coronated with a crown of thorns. And yet, on that Easter day, he was resurrected. In spite of Corona, we will be resurrected. That is, I think, the message of Easter. It need not be a religious message, but if it is Easter Sunday, certainly from any disaster, we will be resurrected, like somebody presumably was. I have no doubt. The specialty, all of us as individuals, as humanity, will be resurrected. Good luck to you all. The times of COVID shall pass. That I promise you. Thank you.
Thank you, Kishore. Thank you very much.
Thank you, Kishore. And Kishore, interestingly, there has been a lot of congratulatory messages. Very, very inspirational. And I think probably if you remember some good jokes, they would want to hear that as well.
My good jokes don't do well on television and internet, Sanjeev.
The other thing was, I was trying to remind Kita, do you remember about 2 weeks before we went into lockdown, the two of us were sitting in the doctor's room, and I was asking you about whether the midterm conference would happen, and you said, why not? So it is, so we live for the day. I think things can just change in 24 hours. So like Kishore said, tomorrow is just another day. I think we just have to wait for tomorrow and pick ourselves and move on. What do you say, Kita?
Absolutely. I think one of the things that I've been reading is that in times of adversity like this, when there is global adversity, I believe people tend to work together, and that might be something that we will take home from this. That despite whatever the threat that might be, that we will continue to work together, and that would result in the quality of our lives improving rather than becoming worse.
Yes, nothing greater than saying, united we stand, divided we fall. And, that's really the message we need to take away from here. Teamwork.
Right.
And make sure that we don't pull each other down. The crabs in the basket scenario will no longer work. We've got to make sure that all of us get out of that basket and keep moving to greater things. No longer frogs in a well. We've got to come out and look at the well. That needs to be the specialty.
Right, Preetham.
Yes, sir. Okay. Thank you, Kishore sir. Thank you, Krishnamurthy sir and Sanjeev sir. Let me also thank Kumar and Jimson on the background and the YouTube taking all the questions, passing on the questions to co-host. It was a great session, and the messages are pouring. Everybody, thank Kishore sir for coming back after 8 years and giving a lecture for AOMSI. Thank you, sir. We knew that this is going to be great, but I think it was beyond what we actually thought.
We had 550 people attending, listening to your lectures, sir. Even at the end, we had 550 people, constantly 550 people.
Thank you. I mean, there's always, at the end of every lecture, I say, there's a lecture you intended to give, the lecture you actually gave, and then the lecture you wish you had ended up giving. There's three different things. So I think something and we ended up saying a lot of things, and I enjoyed doing it. And thank you again for having me. 8 years is a long time. It took a long time coming back, and it was by choice, and I'm happy.
Thank you, sir. It was a great lecture. We all enjoyed it. Definitely, every one of us enjoyed the lecture. for all our viewers and our members, please subscribe to AOMSI YouTube channel, and we'll continue with our next webinar tomorrow. We have Dr. Pankaj Chaturvedi tomorrow in our webinar. Thank you all, and Kishore sir, thank you for the co-host team. Pramod,
Thank you.
thank you. And
Yes.
Praveen, can we end with the music again, please, which is composed by Pradeep Christopher. Thank you.
Thank you so much, Pritam. Bye-bye.
Thank you, sir. Bye, sir.
Thank you.